Hello, my name is Kevin Downs. I'm a pediatric infectious disease physician at the Children's Hospital of Philadelphia, an assistant professor in the Department of Pediatrics at the Perelman School of Medicine of the University of Pennsylvania. And I appreciate the opportunity to speak with you all today about vaccine hesitancy. I do want to make a disclosure, since this is an educational lecture, that I have, or my institution has received research support on my behalf from Merck for participation in research studies, including clinical trials, though not related to the content of anything that will be discussed today. So the topic of vaccine hesitancy is a really important one for healthcare providers. Vaccine hesitancy was identified by the World Health Organization as being one of the most important threats to global health. And the reason that it's an important threat is because it impacts not only the health of children, but the health of adults. Vaccine hesitancy is a complex topic, and I do want to make the distinction that vaccine hesitancy does not mean anti-vax. Anti-vax is the concept where someone is vehemently opposed to vaccination for any number of reasons. And this very small group of people, although very vocal, is different than the number of individuals who are hesitant about vaccines, which really means that you question a component about vaccination, whether it be the safety or the efficacy of vaccinations individually or globally. And vaccine hesitancy is complex because it involves a number of things, such as complacency, convenience, and confidence. But it has a big impact on the overall health of our global population because of the impact that it has on health. For instance, it's recognized as being one of, if not the most important public health interventions to protect children ever on the scale of sanitation and other enormous public health measures. And resistance or hesitance to receive vaccinations can really influence not only national health, but global health as well. And we've seen this occur in the last decade as we've seen issues with anti-vaccination movement rise and vaccine hesitancy increase. In the Democratic Republic of Congo, we saw a number of deaths and more than 300,000 cases occur from measles as a result of inadequate vaccinations. In 2019, there was a very large outbreak of measles in the country of Samoa that resulted after a dramatic decrease in vaccination of measles-containing vaccines in that country. And we've even seen issues with ongoing polio that have resulted from inadequate vaccination. Despite polio being targeted for eradication for more than a decade, we still have yet to fully accomplish that goal, largely because of inefficiencies in our vaccine programs to really be able to reach the number of individuals that are required to eradicate that infection. And the issue of vaccine hesitancy also extends to other diseases for which vaccines have been more recently developed. Ebola has been in the forefront of worldwide attention because of the devastating effects it has had in the Democratic Republic of Congo. Unfortunately, that outbreak was recently completed or recently successfully treated, but it would have been more successful had the uptake of the Ebola vaccine been able to be more widespread. And there are concerns as well that this might happen with COVID-19. So we're all familiar with the devastating effects of COVID-19 globally. Certainly in the United States, we continue to struggle with getting this virus and this pandemic under control. There's hope that a COVID vaccine is going to be what finally ends this pandemic worldwide, but uptake of vaccination is going to be a concern. You know, there's a big rush to get a vaccine ready and out and available, and to make it scalable to the global environment is going to take a huge effort. But there are concerns about whether this is going to be whether it's going to be tested and safe, and so there are as well going to be concerns about whether people will actually accept a COVID vaccine. Certainly, safety is a priority, but also effectiveness. And as with any vaccine, newer vaccines are just less likely to be accepted. And so I think while many of us put our hope in a vaccine against COVID-19 as being the long-term solution, we need to make sure that people are going to be willing to advocate for it as well as take it. And the impact of vaccine refusal has been shown in a number of studies, but I highlight this one because I think that it really demonstrates the importance from a healthcare provider standpoint to advocate for vaccines and their safety. So this was a study that was published back in 2016, which reviewed published literature that looked at the association between vaccine delay, refusal, or exemption, and measles and pertussis outbreaks in the United States. Now, measles was declared eliminated in the US in 2000, but we have continued to see outbreaks occur. And these authors identified 18 published studies involving measles outbreaks in more than 1,400 cases. A number of those cases, 178, were in children less than 12 months in the United States. They would not be eligible for vaccination, though in other countries we know that they vaccinate with measles-containing vaccines down to 6 months. And you can see that more than 50% of cases of measles occurred in individuals who had not received measles vaccination. Even when they looked at just those where there were detailed vaccination data available, which was 970 cases, 59% were in unvaccinated individuals despite being vaccine eligible. And a vast majority of those, 70%, are individuals who had non-medical exemptions. So these were people who refused to get vaccinated or refused to give their children vaccine despite there being no medical indication, no medical contraindication for vaccination. And in the 32 outbreaks of pertussis that were included in this study, in the more than 10,000 individuals, 5 largest statewide epidemics had substantial portions of unvaccinated individuals, ranging from 24 to 45%. So for both measles and pertussis, where we have a long track record of safe administration of these vaccines, a large number of outbreaks are occurring because people are not receiving their vaccines, not because the vaccines don't work. And last year in the United States, we had a large uptick in the number of cases of measles. Many of these cases that are on the right-hand side in 2019 were driven by under-vaccinated individuals in areas such as New York. And it really became apparent that this is continuing to be a problem. Measles is an extraordinarily contagious disease. Small dips in the number of individuals who are vaccinated can lead to outbreaks. And this is what we saw occur in the United States last year. We also saw this happen globally as well. Reported here from the World Health Organization are the number of confirmed measles cases worldwide. And you can see a large increase in those numbers globally. And I want to highlight a couple of cases, and I mentioned them earlier, where we really saw that under-vaccination was what led to these outbreaks. The first was in Samoa. And in a country of 200,000 people, there were nearly 6,000 confirmed cases of measles. That means that almost 3% of their population developed measles. And the only way that that could occur is in the setting of under-vaccination, because the measles vaccine is really very effective when given. And this unfortunate outbreak led to numerous deaths and a high mortality rate in those that contracted the disease. And a large number of those were in children and very young children. And these are preventable deaths. I won't get into the details as to why under-vaccination occurred in this country, except to say that there was an incident that occurred a few years ago that really led to issues with trust of the vaccination program and substantial decreases in vaccination in that country. And what we can see reported here are the percent of nations receiving measles-containing vaccines. This is as of 2018. And each country is represented by a single dot on this graph. And in order to get herd immunity, which is what many people rely on or make an argument in terms of from the anti-vax setting, is I don't want my child to be vaccinated, but we will benefit from other people being vaccinated. For measles, which is such a highly contagious disease, herd immunity occurs when about 95% of the population are vaccinated. And you can see that there are a number of countries who don't meet that threshold. And for Samoa, they fell very far from that goal. They were down in the 30% range. And so they were just primed for an outbreak, and in fact, that's what occurred. And we have concerns that something similar might happen just as a result of coronavirus. So coronavirus and the ongoing pandemic has led to dramatic drops in routine immunization. So even in countries where people would normally get vaccines, we're seeing dips in the number of people that are going to get those vaccines because of concerns about going to a healthcare provider and the risk that might hold. As well, however, just because of the impact of the pandemic on the national infrastructures in a number of countries, there's been a suspension or disruption of vaccine programs in at least 68 countries, and estimates that this could impact more than 80 million children under age 1 for the routine vaccines that they're supposed to receive. So many of us, in fact, all of us in the healthcare industry taking care of children should be concerned about surges in vaccine prevention in the coming months, particularly for our youngest age children. As they get back into daycare and school, there's concerns about new outbreaks developing because of the impact of COVID. And this is a figure from a paper published a few months ago that looks at the rates of measles-containing vaccines, and which are the dotted lines in the United States. And what you can see as we move from January to February to March, we see a dramatic decline in the number of measles vaccines that were given in the United States. And this is really what has us worried as children are potentially going back to school in the fall, that we may see an uptick in outbreaks of vaccine preventable illnesses. And back to that report about measles and the impact of coronavirus, I do want to make a comment about some countries that are particularly at high risk, and Ukraine is one of them. Ukraine saw vaccination rates decrease in 2008, which was above 95%, down to the 30% range in 2016. Now those numbers have improved since then, but they're not back to the height that we would need to see in order to have widespread protection. And in fact, in 2019, Ukraine had more than 57,000 cases of measles, which accounted for more than half of all the cases in the World Health Organization's European region. So with coronavirus ongoing, this continues to be a problem for Ukraine and for its children. So what do we do about vaccine hesitancy? Again, I want to draw attention to the distinction between anti-vax and vaccine hesitancy. For those people that are involved in the anti-vax movement, which fortunately is a small but loud number of people, it's unlikely that our efforts as healthcare providers are going to change their minds. The conviction that's shown by the anti-vax movement is not one that is likely to sway as we provide them with more data, counter arguments to their stances. However, there are a number of people that hear some of the things that are said by the anti-vax movement and say, you know, maybe that makes some sense, and that leads to vaccine hesitancy. And while there are a number of things that countries can do or healthcare systems can do in terms of social media and advertising and improving access to vaccines, as a healthcare provider, that's beyond what we can do as an individual practitioner. However, each one of us needs to be an advocate for vaccines. And in order to do that, we need to increase knowledge amongst patients as well as our colleagues, and increase awareness about vaccines and their safety. And so I'm going to spend the remainder of the time talking about what are the concerns about vaccines and how do we address them. Well, first things first, we know that vaccines work. Based on the available evidence, a single dose of MMR vaccine confers about 93% protection against measles, and it's 92% effective in preventing secondary cases among household. If someone were to get 2 doses of MMR, that's 97% effective. So the vaccine works to prevent infection. However, we need to make sure that people get those vaccines. If we look at MMR in terms of preventing mumps, it's slightly less effective with efficacy of 64 to 66% with one dose, but then that number jumps significantly up to 83 to 88% for 2 vaccine doses. And a single dose of MMR is 97% effective against rubella. So this vaccine really works, but we have to give it to people, and just given the amount of just how contagious measles is, we need to make sure that everybody gets it. We can also see the impact of pneumococcal vaccination on invasive pneumococcal disease. And this has been a really big success story in the United States and other countries that have implemented widespread pneumococcal vaccination. So reported here is our data a Danish study of a population-based cohort. They looked at the incidence of invasive pneumococcal disease and mortality pre-pneumococcal vaccination following the licensure of a 7-valent pneumococcal conjugate vaccine, PCV7, and then following PCV13. And what's really nicely demonstrated by this study is that it not only impacted those that received the vaccine, but it also impacted those that are around children who are vaccinated. So on the right-hand side, what you can see are that the number of cases per 100,000 population, the incidence of invasive pneumococcal disease in the pre-pneumococcal conjugate vaccine era in red, then following the licensure of PCV7 in blue, and then following PCV13 in gray. And what is demonstrated nicely here is the dramatic decrease in invasive pneumococcal disease following licensure of both of those vaccines in not only young children less than 4 years of age, but also in elderly patients greater than 65, demonstrating the protective effects of vaccinating children in other vulnerable populations. And in fact, they saw a 71% reduction in children less than 2 years of age, and an overall mortality rate declined by 28%. Now, I put this quote up here because I think it's an important one when we think about vaccinations. So this is a quote by George Bernard Shaw. "The moment we want to believe in something, we suddenly see all the arguments for it and become blind to the arguments against it." As someone that is a proponent of vaccines, it's easy to say, well, why would you not want to vaccinate your child? We know vaccines work. We know they're safe. You know, this seems like the best thing for all children. But it's important to understand the arguments against it if we're going to help educate those that are vaccine hesitant, those that have questions but are open to information and to data. So what are the arguments against vaccines? The ones listed here, and we'll talk about each of these separately, are really the main arguments that are made by the anti-vax movement. And I think it's important to recognize each of them while talking about why they are actually misinformation when it comes to vaccinations overall. So the first argument against vaccines is that diseases are safer than the vaccines. Why would we need a vaccine for something like measles? No one dies in the United States from measles. Well, we know the facts in that each of the diseases are far more dangerous than any of the vaccines. But there's also a concern that the vaccines themselves don't provide enough protection, that the diseases don't cause the infections don't cause real disease, and that's what children need to have immunity. You hear the argument many times, my child's never been vaccinated and they're far healthier than other children. Well, the fact is that this does not actually hold water, and the risks of natural disease are not, in fact, low. We are fortunate to be in an era where many vaccine-preventable illnesses are quite rare, and many healthcare providers have never seen the actual infections themselves. There was a report published in the New York Times, written by Peter Hotez, who really tried to get this point across, and I think this does a nice job. So on the left-hand side here, this is a visual representation of the effects of the disease itself. This is now talking about measles, and the effects of the vaccination on the right-hand side. So for every 10,000 people who get, we would see about 2,000 hospitalizations. We would see 500 children who get pneumonia, and we would see up to 146 deaths per 10,000 people. This is based on data that was reported just out of the outbreak from Samoa. Now, if we compare that to the impact of MMR vaccinations, so for every 10,000 people that are vaccinated, only 3 develop fever-related seizures. Now, that's not to say it's nothing, but that risk is very, very low. And the risk of someone having a severe allergic reaction, an anaphylactic reaction, is 0.035 cases per 10,000 immunizations that are given. So looking at these numbers, I think it's hard to make an argument that the vaccination actually, the risks of vaccines outweigh some of these potential harms that we see just from the natural disease itself. And we can see similar things with influenza vaccination. So for every 10,000 people who got flu in 2017 to 2018, we saw 180,014 deaths in the United States. That's 1.4 deaths per 1,000 people. If we look at the effects of 10,000 vaccine flu administrations, again, allergic reactions less than 1 per 100,000 people, and Guillain-Barré syndrome, which has been very rarely linked to flu vaccine, seen in 0.01 to 0.03 per 10,000 vaccines. So again, making the argument that the flu shot is more dangerous than the disease really does not, is not supported by any information. And then another important piece that we can glean from this is that 1.4 deaths correlates to, 14 deaths correlates to 1.4 deaths per 1,000 people. The current COVID pandemic, the estimated mortality rate is around 1%. Now that number may not be exactly accurate because of our inability to identify asymptomatic cases, but saying that COVID is the flu is really not an accurate statement by any stretch. And so the need for a vaccine is readily apparent with the ongoing COVID pandemic. And even if we get to diseases where we're looking at if we look at something like HPV vaccine, which I think people question its use because it's not like the flu. It's not like measles where you're preventing an infection that is easy to see. Instead, you're preventing a long-term ramification of cervical cancer. Well, people who get HPV, or women who get HPV, every 10,000 women who get HPV, 3,000 deaths would be attributable to cervical cancer within 5 years of that diagnosis of cervical cancer. So the death rate from HPV-prevented cervical cancers is quite high. The number of adverse events related to HPV vaccine, again, extraordinarily small, despite what might be glorified as a high number. Really, fainting, which is not a significant adverse event, but does occur following this vaccine, occurs in 0.8 per 10,000 vaccine doses administered. So again, an extraordinarily low rate of adverse events from this vaccine. The next argument that gets made against vaccines, or another argument that gets made, is that they haven't been effectively studied because there's no placebo-controlled vaccine studies. Well, this is blatantly untrue because we know that for any vaccine to be licensed, there needs to be a randomized trial. The question is just, what is it randomized? What is the control group in that randomized controlled trial? In you could have a placebo-controlled trial because there was no comparator. However, if there's already a known vaccine that's safe and effective, it's unethical to randomize a child to an unvaccinated group. So we can't necessarily create randomized controlled trials when vaccines that work and are safe are available. That would be unethical. And so when people make the argument that we need to randomize children to receipt of the vaccines per the current schedule, that would really be unethical to do, knowing that we have a safe and effective vaccine that exists. So we do rely on other types of studies, again, which people will use to say, this is not the right type of study. But the fact is, we have vaccines. You can't not use them once we know that they're safe and effective. But people will also argue, well, why don't we have saline placebo-controlled vaccine studies? Well, we have many saline placebo-controlled studies that have been published. And the next argument against vaccines is that we don't have vaccines studied at the current schedule in a randomized controlled way. And no matter what argument is made in terms of the appropriateness or the number of randomized controlled trials, there will be some counter-argument that says, well, it's not exactly the way that we'd like to see studies done in terms of what comparator group that we need. And so the argument continues to shift. And it raises this idea of the no true Scotsman fallacy, which is a process in which one attempts to defend a position against a counter-argument by changing the group to which it applies. So an example of this is that one would argue there's no placebo-controlled vaccine studies. Well, there certainly are. But then they say, well, there's no placebo-controlled vaccine studies using saline as the control. Well, there are those too. And then they say, well, not when the saline is the control while giving vaccines according to the current schedule. And my point of raising this is just that it's very difficult to counteract or to counter an argument that continues to move. And so we just need to be aware that what the argument against vaccines may be, we may not be able to completely have a discussion with people that continue to shift the basis for which they want the studies done. At this point, with the vaccines that we have available, licensed, shown to be safe, shown to be effective, we cannot do a study in which we take a group of completely unvaccinated children and compare them in a randomized way to children who get vaccinated. That would be unethical, it would be infeasible, and that would be unsafe for children that are randomized to the unvaccinated. Saying that we can't do that study is not an argument against vaccines at this point. Well, others will say that there's too many vaccines that are available. There are dozens of vaccines given to our children, and it's not safe to give them so many vaccines. In fact, in the United States, in the first 2 years of life, children will get vaccinated against up to 14 different infections, can receive up to 27 injections, including up to 6 shots at one time. And the argument here is that this increase in the number of vaccines over time has directly increasing incidence of autoimmune diseases, autism, asthma, you name it, any number of infections or a number of conditions that has seen an increasing diagnosis over the last 10, 15 years can be directly related to the number of vaccines that are given. Well, why doesn't this argument make sense either? Well, the fact is, currently, there are 160 unique immunological components across all of these vaccines that are licensed. And if we think about the infections that they're preventing, or all the types of infections that we encounter, thinking that 160 unique immunological components would overwhelm our immune system just doesn't make a lot of sense. Viruses contain anywhere from 3 to hundreds of distinct antigens, and bacteria and fungi contain hundreds to thousands of unique antigens. So when a baby's first born and they're exposed to the environment and their microbiome develops, whether that be their intestinal microbiome, their skin microbiome, they're exposed to trillions of antigens over those first few years of life. And to imagine that the administration of vaccines is too many antigens to handle, whereas their natural exposure to all of the possible bacteria, viruses, and fungi that they encounter in just being alive in the world does not add up. And then, well, people will argue, well, while individual vaccines may go through extensive vetting, an individual vaccine can be safe, but the entire vaccine schedule has never been collectively tested. And so this was a question that was actually looked at in 2013 by a group of diverse individuals from the scientific and ethical and committees put together. The committee was made up of scientists, researchers, as well as ethicists and others invested in this question. And they tried to look at whether the vaccine schedule itself could be linked to autoimmune diseases, asthma, and a number of other conditions that have been reported. And the committee found that there was no significant evidence to imply that the recommended immunization schedule is not safe. And this extensive evaluation looked at numerous possible correlations and found that there was no evidence to suggest that the vaccine schedule itself is an issue. So another argument that gets made is that all of these vaccines are overwhelming the immune system and it causes immune dysregulation. And so that's why we see these autoimmune diseases. And this has been looked at in a number of studies, looking at the association between vaccines and individual autoimmune diseases, as well as autism, atopy, asthma, any number of studies. And so I'm not going to present all of the data, but just show a handful of studies that show that this is not the case. This is a publication from 2018 that looked at how many antigens someone is exposed to in those first 23 months of life, and then non-vaccine targeted infections. So does being vaccinated make you more susceptible to other infections? They looked at children who developed non-vaccine targeted infections who had been exposed to an average of 240 antigens from vaccines, and children who did not develop such infections who had been exposed to an average of 240 antigens from vaccines. And they found no correlation between the exposure of antigens through vaccines and the risk of developing other non-vaccine targeted infections. So getting vaccinated does not make your immune system weaker. Other studies, as I mentioned, have looked at the association between vaccines and autism, which we can clearly state at this point is not related to immunizations, as well as things such as inflammatory bowel disease, which has been clearly, although has been argued to be associated with vaccines, there's no data to clearly link immunizations with the diagnosis of Crohn's disease, ulcerative colitis, or inflammatory bowel disease as a whole. And again, this was a large report published in 2011 that looked at all of the evidence for both association and causality and found no association between MMR vaccinations and autism and diabetes, no association between DTaP vaccination and diabetes, and no association between influenza vaccination and exacerbation of asthma. And we've seen many publications as they continue to be done, well-designed studies, systematic reviews, meta-analyses that continue to come to the same conclusions, that vaccines are not associated with a number of diseases to which they've been attributed. So the next argument that I think is important to recognize is that people will say that vaccines contain toxins. So mercury, aluminum, formaldehyde, all these toxins that are contained in vaccine, they're harmful to children. How can you give your child toxic vaccines, given the things that are contained within them? So what's the truth about these toxins? Well, the argument started with thimerosal, which was a mercury-containing preservative. It was present in several vaccines used in the 1990s, DTaP, Hep B, and Hib. And even though it was never present in the MMR vaccine, mercury was supposedly associated with autism. Even though there's been no evidence to link thimerosal to any actual adverse events, it has since been removed from all routinely used childhood vaccines. So anyone arguing that mercury is contained in vaccines is the truth. The only vaccine in which there is any thimerosal are multi-dose vials of influenza vaccine, and there's been no suggestion that there's any link between that and any type of adverse event such as autoimmune diseases or autism. And so really there's no argument that holds water currently in terms of mercury and adverse events. And another piece that's important to recognize is that ethyl mercury, which is actually the type of mercury that's in the flu vaccine, is much less likely to cause any adverse events than methyl mercury, which is the mercury that's in the environment and is known to actually cause harm. So I think the mercury argument is largely void at this point. But now you'll see more people claiming that aluminum is actually the toxic agent in vaccines that causes most of the harm. Well, aluminum is used in vaccines. It's a common adjuvant that's used to enhance the immune response. So by including any type of adjuvant, the manufacturers to do is include smaller amounts of the actual active component to which contain less antigen by developing a more robust immune response. And aluminum salts were approved as adjuvants in 2009. Again, the reason I state that is because that's well after the first claims of links between immunizations and autism. But it's important to recognize how much aluminum does a child actually get. So in the first 6 months of life, infants will get 4 milligrams of aluminum from vaccines. That's how much is contained in it. And the question is that a lot or is that a little? People would argue that's way too much. But the fact of the matter is it's really not, because concentrations of aluminum in the blood following vaccinations don't change. People have looked at this, tried to measure aluminum concentrations in the blood, and they don't change after individual immunizations. And this was something that is included just to show how much aluminum is in vaccines. And again, we're saying 4 milligrams over the first few months of life. So how much does that impact them? Well, this was a study on the left-hand side is a figure looking at how much aluminum would be in the body in order to actually cause toxicity versus the days of age on the x-axis. And so they did a number of modeling steps to try and look at how much aluminum is contained in each vaccine, how much would be retained within the body, assuming that children had, because aluminum is removed by the kidney, how much would still be there based on normal renal function for infants. They looked at the kinetics of aluminum at the site of injection. So, right, it's not injected straight into the bloodstream, it's injected into a muscle. And so when it leaches out into the bloodstream, how much aluminum would we really expect? And the blue and the red lines on the figure demonstrate potentially toxic levels. But the green and the yellow are actually what we see from formula and breast milk. And the black line there on the bottom is how much you could expect with all of the immunizations that contain vaccine given. And you can see that it is nowhere close to the amount that actually would be seen with toxicity. So the concern that the amount of aluminum is given actually causes toxicity does not account for the fact, doesn't account for how the body handles aluminum, and that children can, even though there is aluminum in the vaccines, children will eliminate that from their body, and that it's not a risk to children. And so the last toxin that I wanted to mention is formaldehyde. Formaldehyde is used to inactivate viruses such as polio and hepatitis A, and detoxify some of the toxins, diphtheria and tetanus, and make them safer to administer. And people will say, well, how can you inject formaldehyde into a child? It's an embalming fluid. You can't possibly give that and think that that's not a toxin. Well, the fact is, formaldehyde is actually a naturally existing product or byproduct of DNA and protein synthesis. So we all naturally have formaldehyde in our bodies. In a newborn baby, the amount that they will have is more than 1,500 times that contained in any given vaccine. So the idea that we're injecting large amounts of toxic formaldehyde into a child is not true. And most vaccines contain anywhere from 0.005 to 0.1 milligrams in an individual shot. And over the first 2 years of life, infants are exposed to about 0.7 to 0.8 milligrams of formaldehyde through vaccines. Well, what does this mean? Is that a lot or is that a little? The answer is that it's not a lot, and it's quite safe. So if we look at it compared to other sources of formaldehyde, the most common exposures are just from the environment, from air, from gas combustion, from secondhand cigarette smoke, or for cigarette smokers and e-cigarettes. We see far more formaldehyde exposure from those things. And to put some context about where 0.7 to 0.8 milligrams lies, secondhand smoke is a significant source of formaldehyde exposure, and it's estimated at 0.02 to 0.06 milligrams of formaldehyde per cigarette in the second. And for e-cigarettes, it's about 10 micrograms of formaldehyde per puff, which adds up to about 8 milligrams per day for someone that uses e-cigarettes. So that's just to give you some context about how much formaldehyde is in vaccines. And on the right-hand side is a graph looking at toxic effects. So this was looking at, in animals, how much formaldehyde would exposure in a chronic sense would lead to toxicity. And this is in milligrams per kilogram per day. So if we say no effects are seen until 50 milligrams per kilogram per day, clearly the total amount of formaldehyde in vaccines is nowhere close to that. But put it in context of chronic exposure, even if you gave all of the vaccines that are given over the first 2 years of life, which add up to about 0.8 milligrams of formaldehyde, that would still only add up to 0.16 milligrams per kilogram for a 5-kilo infant. So if you give them all at birth, that would still be below the amount of exposure that you would need to see per day in order to lead to toxicity. And so which vaccines contain what? It's important just to recognize that there are these components of vaccines, so that when someone says, I'm concerned about this vaccine or the other, you can have a discussion about, well, it's not that is contained in this vaccine or that vaccine, and have a discussion about the safety of those vaccines specifically. Another argument that gets made against vaccines is that vaccines come from aborted fetuses, and so that they are ethically unable to give vaccines or to receive vaccines because they are derived from fetal tissue. So where does that argument come from? Well, there are two commonly used cell lineages that were derived back in the 60s, from which many or several of the vaccines have been cultivated. So in 1961, the WI38 strain derived from a female fetus that was therapeutically aborted in Sweden, and those fetal cells have been used to grow a number of vaccines in cell culture. MRC5 was developed in 1966, again from a therapeutically aborted fetus, and because of how difficult it is to cultivate vaccines, these particular cell lines have been very successfully used since that time. So it's important to recognize that they were derived more than 50 years ago and continue to be in existence now. It's not that there are new fetal cell lines that are being derived. The rubella virus itself, for the vaccination, was derived from explanted kidney tissue of a fetus in 1964, and that rubella strain has been propagated serially many, many times since that time. But these cell lines have served as viral culture media for millions of vaccine doses, and their safety is not questioned at this point. The reason that these cell lines continue to exist is because, one, they have been studied repeatedly for years and years, and we know that they are safe. We know that they also are reproducible, and so that we can make vaccines using these cell lines very successfully and consistently. And it's important to recognize that no additional abortions have ever been performed in order to maintain these cell lines. So the argument that vaccines come from aborted fetuses, while the cell lines were derived more than 50 years ago, I think that argument is a little bit misleading, suggesting that babies are being aborted in order to actively make vaccines, and that's not true. But nevertheless, knowing that these cell lines have been derived from what were originally abortions, the question came up: is it ethical to use vaccines that come from these cell lines? And so this was reviewed by a team of ethicists back around 2013. The National Catholic Bioethics Center and the Vatican's Pontifical Academy for Life, really reviewing, can we use cell lines for vaccinations that come from abortions? And they concluded that vaccination is not contrary to being opposed to abortion, and that it is in fact the parental duty to give vaccines. So they said that, and I quote, "Teams agreed that the use of a vaccine in the present does not involve sharing in the action of those who carried out the abortion in the past." And so, in fact, it is not only ethical to give vaccines that were derived from these fetal lines, but also that it is the parental duty to do so because it protects their children. There are a number of religions or people affiliated with a number of religions that have claimed non-medical or religious exemptions, saying that my religion forbids me from giving vaccines due to a number of different causes. And it's worthwhile recognizing that currently no religion opposes vaccination. To say that there is a religion that vaccination is blatantly not true. But it's also important to recognize what are the arguments that state a religion can't give vaccines, because even in this case, that has not been supported by the leaders of each of these religions. So for Hinduism, there is no current opposition to modern vaccines. For Buddhism, which is a religion that prohibits the killing of humans or animals, there's concerns that because of the way that the viruses the vaccines are derived, that it involves testing in animals or testing in humans, and that's not ethical. But there's no truth to that, in that there's no opposition to modern vaccines for the purposes of protecting life, because vaccines, their benefit is so substantial. And then I just want to jump down to Judaism because of the concerns about possible because vaccines could contain products that might be unable to individuals of that religion. And I jump forward here because gelatin, which is porcine derived, is added to stabilize the active components of some vaccines during storage. And trypsin, similarly, may be used in some viral vaccines in order to allow the virus to be drawn up from the culture dish. But both Jewish and Muslim scholars who both are opposed to use of porcine, or to ingestion of porcine products, have decreed that these products are okay for use as vaccines because, one, components have been significantly transformed from their original animal product, and so they don't represent direct injection of a pork product. Also, there are such minute doses of these products contained in vaccines, and because of how important vaccines are for medical use, and lastly, because injection does not equal ingestion. So someone that is of the Jewish or Muslim faith, stating that they cannot receive vaccines from their because of their religion, may actually be inaccurately interpreting the text from which they think that derives. And recognize that many of the religious objections currently are in fact personal, social, or cultural objections, or based on misinformation. And so this is an important conversation that you may be able to have with your patients in order to allow them to receive vaccines. And so the last argument I want to discuss against vaccines is one of medical freedom. We're seeing this at the forefront of the coronavirus pandemic in the United States when it comes to wearing masks, in that people don't like being told what they have to do. They don't like being told that it's in their best interest to do anything because they want the freedom to make that decision for themselves. And so how does this argument play out for vaccinations? Well, the argument really stems that, or really is made, that parents have the right to choose what is best for their children, and that mandatory vaccination violates the rights of parents to do what is best for their child. And this is the argument of medical freedom when it comes to vaccinations. Well, while that is an argument, unfortunately for them, or unfortunately for parents making this argument, what's in the best interest of their child does not necessarily mean what's in the best interest of the parents. And many ethicists have looked at this and argued that parental rights must be based on the best interest of the child, not the perceived best interest of the child. And when weighing the risks and benefits, it is in the child's best interest to be protected from potentially harmful or deadly infections. And the safety and potential benefits of vaccines far outweigh their risks, and therefore vaccination is in the best interest of all children. So the argument that parents have the right to choose what's best for their children only holds when that decision is actually what's best for that child. And currently, based on the overabundance of data supporting vaccines, it is in the best interest of children to be vaccinated. And that's the argument and counter-argument against the medical freedom stance against vaccines. And it is very difficult to counter that argument because parents want to do what's best for their child, and they believe that what they're saying is what's best for their child. But it's important to recognize that vaccines, from an ethical standpoint, are what's in the best interest of children. So how do we talk to parents about vaccines? Or how do we talk to colleagues who might have questions about vaccines? Well, the first thing, and one of the most important things, is to listen to their concerns. It doesn't do anybody any good to walk in and say, this is the best thing, I don't care what you have to say, this is why you have to vaccinate. In fact, you want to understand, where are they coming from? when a parent says they're reluctant to give vaccines, why are they saying that? Many times, giving a personal story may be beneficial to really help explain why, why you feel as strongly as you do in terms of why it's important to vaccinate. And then follow that up with data on the safety of vaccinations. So when we listen to concerns, it's important to recognize that past negative experiences can influence vaccine hesitancy. So a child gets a flu shot and gets a fever afterwards, that may be potentially, cause some angst for the family, and they're worried that they're going to get additional fevers with each vaccine. And so it's important to recognize where the parents coming from when they say that they're hesitant to give vaccine. And also recognize that many times the vaccine hesitancy that a parent is putting forth, they read something on social media, they heard something from a friend. And so understand where does their hesitance come from, because then you might be able to have a more directed conversation about why that concern is something that we shouldn't worry about, or potentially understand maybe it's something with an individual vaccine but doesn't apply to every vaccine that is to be given. Again, personal stories are helpful. Knowledge of someone who suffered from a vaccine-preventable disease. If you've seen children with measles, you know how devastating that infection can be. And trying to explain to someone who's never seen that disease what it looks like may really have more sway than just saying, well, measles is bad for you. And giving example of vulnerable children and why it's important to vaccinate from a public health standpoint is another important thing. So we know that vaccination might not only protect that individual child, but might protect others that cannot be vaccinated. And making that argument to people is important. That may not be enough to convince someone to vaccinate their child. The idea that doing good for the good of others doesn't always make people individually do good, but for some it may. And lastly, knowing the data is important. Be willing to review the vaccine information with with families, with patients. There are some adverse events that occur, like fevers, injection site reactions, etc. And things like that do occur following vaccinations. You feel kind of crummy after you get the flu shot. That doesn't mean that it's unsafe, but you need to tell people about them so that they're not saying, "Oh my gosh, I caught the flu from the flu shot," which we know is not possible. And recognize that it's very difficult. Newer vaccines are particularly ones that are hardest to gain acceptance. This is something that we're definitely concerned about for coronavirus vaccination. If the scientific community develops a vaccine that is shown to be effective and shown to be safe, there's going to be a subset of people, or a potentially large number of people, that are unwilling to get it because of concerns about safety. And we need to recognize that people are going to say, well, I don't want it, I'm going to expect everyone else to get it. And we need to, have, to put effort forward to really try to get newer vaccines used more commonly. And so that's the end of the discussion today. I hope that this outlined a little bit of the things that we can do as healthcare providers to try to help people who are hesitant about vaccines, to understand the arguments against vaccination, or arguments that people may have heard. And by recognizing what the arguments against vaccination are, we can provide some information about what vaccines really do, about their safety, and about why many times those arguments are really based on fear and not based on fact.